We are live now, ma'am.
Yeah.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Gestational Diabetes. And this is second episode of Med Mocha Meetup Season 1. And I would like to introduce the organizer of the webinar, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, MRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, infertility specialist. Ma'am is part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am.
Thank you. Thank you, Sahiti. And thank you, Shield Pharma, for providing the platform for this academic feast. Warm welcome to my all dear friends who have joined across the geography. I initiated this series on this few days back only, the Med Mocha Meet. In this, today is the session 2, and I invited here my very dear friend, Dr. Rajeshri, Professor Dr. Rajeshri Katke. And today we are going to discuss regarding the gestational diabetes. Friends, this series I tried to make it the question answer session so everybody will be benefited. So because each and everyone is having a lot of queries related to gestational diabetes, when to do the blood sugar, what are the problems, and when we have to repeat, thousands of questions the patients are asking these days. So friends, as you all know that knowledge is power and knowledge always increases by sharing. More the knowledge we share, more the powerful we are. So without wasting time, I am inviting my dear friend Dr. Rajeshri. Saiti, please do the honor. Please introduce
Yes.
Dr. Rajeshri. Yeah.
Yeah. It's my privilege to introduce Dr. Rajeshri, ma'am. Ma'am is professor and head of the unit OBGY Grand Government Medical College and ex-superintendent of Kama Alblas Hospitals, Mumbai. Ma'am is the renowned obstetrician and gynecologist and surgeon par excellence, medical undergraduate and postgraduate teacher for more than 2 decades. And ma'am has been the researcher, editorial, and author, associate member of RCOG. Ma'am has 100 plus publications in national and international journals, 330 plus citations, more than 180,000 plus global reads. Around 150 papers were presented by students under ma'am's guidance. And
most of them they know me.
yeah. Ma'am has many awards to her credit. I welcome you, ma'am, and I hand over the session to you.
Yes, thank you, Saiti, for
Yeah.
kind words, and thank you very much. Thank you, Ritu, for inviting me on such a beautiful topic. And Ritu, a dear friend of mine, but she's very great now. What we can say is the celebrity in the academic
Hare. Your voice is coming little less, Dr. Rajeshri.
Yes, it is 100 actually.
Saiti, you
Yes,
are able
ma'am.
to. You are able
It's
to.
little bit less than us, ma'am. Yeah.
Less, huh?
Just
Come little closer, Dr. Rajeshri, little closer.
yes.
Yes, now it is little.
Okay.
Yeah, yes, ma'am. Now it is
Yeah.
fine.
Fine,
Yeah, now
no?
it is
Okay,
fine.
okay.
Yeah.
Okay, done.
So, friends, once again, warm welcome to dear Rajeshri. Rajeshri, these lovely roses for you. I know you are a lady with a golden heart, the lady who is always ready to help द फ्रेंड्स. आपको आधी रात को भी कुछ प्रॉब्लम हो, आप राजेश्री को उस टाइम पर भी एक फोन कर सकते हो. शी नेवर फील इरिटेटेड और एनीथिंग. शी इज ऑलवेज रेडी टू हेल्प इन ऑल द फ्रेंड्स. एकेडमिकली भी आपको कुछ पूछना है या आपको सर्जरी के लिए कुछ डिस्कस करना है, शी इज ऑलवेज रेडी. सो आई थिंक this is also the Mata Rani blessing that you are in my life, Rajeshri. Huh?
Yes, same here.
So now, without wasting time, friends, I'm starting the topic of the today. Lot of friends are joining. Friends, today's are the question answer session. As we all know, related to this gestational diabetes. So my first question to you, Dr. Rajeshri, as we all know, that we all are seeing lot of patients of these days are coming of this gestational diabetes. So very important query. आई विल स्टार्ट द जो सबसे इम्पोर्टेंट क्वेरी होती है जितने भी यंग लोग पास होते हैं, या कि इज इट लाइक दैट एवरी टाइम वी हैव टू स्विच ओवर टू द इंसुलिन, or because some patients are reluctant to take the insulin also, some patients want that they should continue the oral hypoglycemic agent. So what's your opinion?
I think first you have to, diagnose whether she is gestational diabetes and how much is the amount of the blood sugar, and what type of gestation she has come. Suppose she is in a first trimester in a period of organogenesis. What I feel personally is that she should be put it on the insulin. That is the better, because at the period of the organogenesis, we should not have some complications like teratogenic and all. Though nowadays it is they said ki metformin and bigloburides they are we are using, but best to use it in the second trimester for the control of the blood sugar.
Acha, perfect. Acha, other thing I want to know, as Dr. Rajeshri, we are seeing lot of patients of the PCOS. In the PCOS patients, yes, of course, we are giving this myoinositol, D-chiroinositol, and in some patients, we are starting. Some doctors are preferring the combination with the metformin also. So, uh, if that patient conceives with the metformin, so what you prefer is that they will continue that medication, or you want to switch over to the insulin? This is a very common query by the lot of doctors.
Yes, basically safely, because they can continue with the metformin. But one thing is that you have to explain to her for the first trimester, for in the period of the organogenesis, if she want to get switch to the insulin just for that period of 12 weeks, and then again you can start with after 14 weeks you can start with the metformin. That is also very good in that. And most of the time, you rightly said that if patients they are on the metformin and they have been conceived already, and they come at around 5 weeks, 6 weeks, 7 weeks sometimes, because they don't know this amenorrhea, and it could be the amenorrhea of the pregnancy. So in that case, so we are taking the risk also in the things in that. And metformin, bigonides, so these are the category B type of the drugs. So because they don't have so much of long data, yeah, big data, what you can say, the duration was not so much of long in these cases. And even the the data across the globe is not very big one also, to tell that they are having some congenital malformations with these drugs only.
Yeah. Perfect. Because what I do in my practice, because I am getting lot of this Google savvy tech patients, they all instead
Yes,
insist, no, ma'am, we don't want to go on the injection.
yes, yes,
We have read so many data, so many papers. We have read that metformin is safe. Yes, of
yes,
course, if they are
yes,
insisting, they can continue.
they
But
can.
in this era, please, better, it's much better to take one signature that you have
Yes,
advised the insulin up to the period of the organogenesis, as Dr. Rajeshri very correctly pointed out. But if the patient is insisting, yes, you can
yes,
mention on the paper and then take one signature to be on the
yes,
safer side. As
yes,
we all know, the chances of congenital anomalies are little higher in the diabetic patients.
yes.
So thank you so much, Dr. Rajeshri, for clarifying very nicely. Now, coming to a very basic question, because this program has been appreciated from the beginners up to the senior practitioners. So now, first question, as we all know, this is a very common question in the Viva we get, that what are the effects on the mother and baby? Macrosomia, we all know, neural tube defects, we all know. So what other things you want, one, two, three, four, you want that, what are the effects on the mother and the baby? Please
See,
highlight
in
that.
the mother, at you rightly said, but they are prone to get any preeclampsia, preterm labors, premature rupture of the membranes, and even some complications. They are more, per se diabetes like retinopathy, nephropathy. Yeah, on the fetus, you will get these chances of abortion, intrauterine growth restriction,
Yeah,
unexplained stillbirths, and IUFD. It is more common in that. And in during labor you will get a prolonged labor, obstructed labor, macrosomia, shoulder dystocia, difficulty during cesarean section, postpartum hemorrhage, either atonic or traumatic. And then comes the difficult cesarean section, difficult deliveries, and in a puerperium chances of getting a sepsis also. So
very
these are
true.
the spectrum of the diseases with the mother. And with these, there are the two things you should look in the mind is that one is per se complications because of the diabetes, that is the one thing, systemic complication. But the diabetes during pregnancy itself gives a more extra complications, and that you have to keep in mind with the mother and the baby also.
True. So please highlight some of the effects on the baby.
Baby, you will get on the baby. One is the big babies, that is the macrosomia, that is the thing. Then congenital malformation, right from top to bottom, if you can say in that. These fetus, they will have a holoprotonocephaly. Then they will have some congenital anomalies at the eyesight. Then they will have the neurological tube defects in that. Then they will have a heart problems also in that. So these are the caudal regression syndromes, spine deformities, bone deformities. So these are the congenital anomalies. Then third important thing is that these babies, they are very prone for the neonatal hypoglycemia, then hypocalcemia. These are very prone because the lung maturity is very less. What it happens in that the baby is having a very big size, or weight will be more, but at compared to that, the lung maturity will be less one. So they are very prone to go for the respiratory syndromes or the hyaline membrane diseases. And chances of birth asphyxia also is in more. And with the delivery with shoulder dystocia, they can have the neurological complications like palsy or the neck twisting and all these things. It happens with the big babies in that.
Yeah. Thank you. Thank you so much for. Meanwhile, I received one question in the YouTube. Uh, this is by Dr. Janum Khan. She has joined all the way from Abu Dhabi. Her question, Madam, you prefer LSCS all the time in gestational diabetic patients, or we can go for the normal delivery also?
No, we can go for the normal delivery. We have delivered also normally the patients, but it depends upon the size of the baby, then size of the pelvis. If suppose you have more than 3.5 kg, 4 kg, 4.5 kg, then it becomes very difficult in that. The second is that the size of the pelvis also, it should be adequate for the baby, and she should not have any complications for that. So not always every diabetic woman, she should go for the cesarean section. That is the thing. So you have to individualize the case, and then you have to deliver it either normally or this thing. And one important thing I would like to say is that Ritu, not every diabetic baby is big only, because if there are angiopathies, you can get a intrauterine growth restriction and small or
Yes.
gestational age babies also. In that you can also go for the normal deliveries also.
Yeah. One thing I want to add, yes, of course, but in the diabetic patients, you need a very close monitoring.
Close monitoring.
So, because the chances of sudden IUD are very high. So, if patient is in the tertiary care center, then no problem. If all the parameters are okay, the proper sugar control, pelvis is roomy, as Dr. Rajeshi has just pointed out. If everything is okay, you can go for the normal delivery also. But if there is
Some
something
issue.
mismatch, so please don't take the risk
Yes,
in
got
today's era, better to go for the cesarean section. Please explain the patient all pros and cons, and if the patient is ready, of course, we can go ahead.
Yes, yes.
So, as we all know that there are lot of patients are coming in this of the gestational diabetes. Suppose if we have done the, I'm taking this practical question because as you are in the government institute, you had done thousands of cesareans. So in the diabetic patients, we have seen that lot of the patients are having the wound gaping or the delayed wound healing. So what are the practical points you want to emphasize on that for the wound healing?
One is the
And all the patients, Rajeshi, are not ready for the resuturing also. This is also a
yes,
big problem.
yes,
A lot of the patients are not ready. Yeah.
yes. One is the
Mm.
important thing is that euglycemic control is very important in that. If suppose that sugars they are deranged, whatever amount of precautions you take, this is going to happen in that. That is one thing. Second is that every patient has their own healing capacity
Yeah.
and the immunity. So that is also we have to explain to the patient. Sometimes you are very good doing in that, and if there is no healing on their part, then if it is a delayed healing, then you will get in that. third important thing is that you have to take a extra aseptic precautions for that, no multiple PV examination. Then there should not be any prolonged premature rupture of the membranes, or start with the higher antibiotics, take precautions for that. While doing the cesarean section also, while doing the catheterization also, keep it catheterize the patient properly under all aseptic precautions. And even doing for the, you have that drapes also, where there will be less of the contamination, and that you can try for that. And there should not be a more prolonged hours for the surgery, light incision to delivery of the baby, and incision to closure to the skin. So it has to be with the expertise, and it has to be a very nice and good closure of that. And one important thing is that while closing the abdomen, because these are the, sometimes they are very obese, so try to get either you can keep a subcutaneous drain or tension switches. These are the very very small things, but it helps in the things in that,
Yes,
because
yes, very practical
because
point you have taken out.
very
The
very
putting of the subcutaneous drain is very, in
it's
sometimes,
very
because
important.
yeah, because sometimes we have done the cesarean. I have done one patient, she was 110 kg.
Yes.
And so it is must that if we can put, it's not a problem if the patient has to stay 1 or 2 day extra, but better
Because
the
that,
patient.
and what happens in that, if suppose the fat is there, that collection it comes out, we get with the syringe that 30 cc, 20 cc, 15 cc, and then, if it is getting collected inside the wound, and if it gets infected, then there is chances of wound adhesions are more. So basically these are the precautions we can take in that. And one important thing is that you can examine the wound, and on day 3, people sometimes do go, they go for a day 5, day 6, day 7. Don't do
No,
that in that. If
no.
suppose no, there are peoples that they go for a day 5, day 6 and all in that. Suppose the collection is there, as early as you can take it out one stitch, and then you can do that. And better, what I feel that now, if they are the obese one, at least you try to explain her about this scar, and take the intermittent, skin matrices. That is better. If you take the subcutaneous, and then if it, then you have to open it, the complete, suture for that. But suppose you have a intermittent, then you can take it out and you can drain it also. That is the advantage of that. So you have to see the patient conditions, and try it. And give for the multivitamins, vitamin C. That is also good for healing post-operative.
Early mobilization is also very
They're
important
very
in that.
important. And anemic, if they
Yeah,
are anemic, then give, that is better for the healing. And
yeah,
they should get mobilized very, and avoid
very.
GS if it is possible. Then they can do with the epidural and spine, depending on.
Very true, very true. Thank you for focusing this very important point. My other query, as we know that most of these diabetic patients are obese diabetes, what we are seeing these days. So, again, this is a question comes in everybody's mind regarding the role of the heparin. So, you want, what you prefer? You prefer to start the heparin or not? Huh?
I think if they get mobilized early,
Hmm.
then you don't have to, because once she is out of, see, for after 6 to 8 hours in that. So many people, they are giving the low molecular weight heparin prophylactic for that, but you have to see the patient's condition and decide. But not for every patient we do give for that actually. But generally nowadays we are doing cesarean section after 6 hours, they get mobilized in that. And then the leg physiotherapy is also very important in that.
That's correct. Yeah,
Hmm.
that all depends, as Dr. Rajeshri told. Yes, but if the patient is morbid
Very
obese,
obese,
if you
then
want, you can
yes,
start also
low
low
molecular
molecular
weight
weight heparin, not a problem.
yes.
Yes, depending on that, all the parameters you have to observe and accordingly.
Okay.
Very correctly you said. If the early mobilization, yes, but we have
And
to focus on.
always when you go for a second day round or the evening round, see for the calf tenderness or the Homan sign. Generally, we have forgot all these things, but this is very important most of the times, unless the patient tells, she is having calf tenderness or
Very
thrombophlebitis.
practical point.
Rarely people they see for the dorsiflexion of the hand, and he see for the dorsiflexion of the foot, and see for the calf tenderness. That is the one thing I think we should be very clear.
Yes.
Very
Yes.
important
Yes.
point, madam. Madam has
Yeah.
pointed out important because to look for deep vein thrombosis, especially after
Yes,
delivery, postpartum, is
yes,
very
yes.
important, especially in
It's,
morbidly obese patients.
Yeah.
And earlier the mobilization, the better. Nowadays, even pre-operative stockings are used,
use.
and
Yeah.
Yes,
the
yes,
legs are
Yeah.
tied with the DPT stocking. Yeah.
yes.
Yeah. That is
Thank
also
That's
you.
much
great.
better. Lot of
Much better. Lot people we are also using that, but depends that when she comes for the elective.
That's correct. That's
Generally,
correct. Yes. Yeah.
generally they
Yeah.
do
There
come
is
for
no
the
such
elective.
tailor-made protocol according to the patients. Yes. Yes. That is a good input. Yeah.
Mhm.
Yeah. So coming to the, as our program time is only half hour, only 5 minutes are left. So now very other important question, which contraceptives are the contraception is of choice for the diabetic patients? What's your opinion?
See, diabetes, if they have completed the history, then either she should go for the tubectomy or the husband should go for a non-scalpel vasectomy. If they want to continue for the fertility purposes, then either she can go for the even PPIUCD is okay in that with cover of the antibiotic. But for the hormonal pills, I feel you have to judge for herself. The body mass index is the one thing. Then if she has a hypertension also in that. If you want to start, you can start with the low dose pills. That will be the contraception in that. And if she is lactational, then you have to be careful while giving the progesterones.
Very true, very true. Thank you. Thank you so much, Dr. Rajeshri. Friends, if there are any questions, you can write in the chat box so I can take that questions. So, Dr. Rajeshri, there is one question I have received. That is a doctor from Dhaka, uh, Dr. Jamur Nisha. Huh? Her question is role of HbA1c, as I told you,
Yes.
and how frequently we have to monitor that HbA1c. Is it
See,
very important to do in the every trimester or what? What are the guidelines?
See, guidelines is that you can see first time when she is coming with the glycosylated hemoglobin if you are suspecting the gestational diabetes or if she is diabetic and she has become pregnant in that. That is the thing. It gives the idea about 3 months of the 3 months of the this thing. But during pregnancy, you can repeat it. According to in 3 months cycle when you are doing a blood sugar, so better to get it that hemoglobin A1C. Though they say during pregnancy, the marker is the best is of fasting and the postprandial blood sugar. That is the thing. But according to that, we have to keep it around 5.7 or the below 6. That is the thing which we feel uh, about the glycosylated hemoglobin. But we are
Yes.
doing it.
Yeah. Yes, of course, these days everybody is doing. It's better to tell the patient to keep it below 5.6. Uh, Last week I had one patient, I told her कि 6 से कम तो होना ही चाहिए. So today she come with the report and it was 6.2. Ma'am, it is okay. It is okay. You told only कि 6 और 6 से नीचे. It's better. While talking, yes, 5.6 is actually the ideal. So you have to tell that it should be less than 5.6 or up to 5.6. That is 5.6 से कम ही होगा तो उतना ही अच्छा है.
Yeah, but 6
So
ठीक है 6 तक. I mean below
हाँ
6.
पर अब the patient
Because
is having
they are on the either anti-diabetic drugs or on the insulin, so they can maintain accordingly with the scale of the blood sugar.
Can I
correct.
make one point?
Yes,
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 Can I
yeah,
make one point?
yes,
Yes,
sure.
yeah. Yes, yeah. In recent Gestational conference, there was a speaker from Israel, and he has done a study on late intrauterine fetal death, and that too, the gestational diabetes was not found in those. I mean, it was not detected in those patients, and even unexplained stillbirth. unexplained fresh stillbirth. So there is a connection between the gestational diabetes and especially what he said that speaker from Israel, all pregnant patients in first and second trimester and third trimester have to have their 99 and 109. That is what figure he has said. The about
Yeah.
fasting should be around 99 and post lunch should be around 109.
Actually, what they see is in
So that is the
diabetes during pregnancy, a slightly hyperglycemic side will be very good. You should not be a very hypoglycemic side. That is the one thing of the unexplained
yeah
IUFDs. In last 30 years of my practice, I have seen even with the controlled diabetes, we have lost the babies in that, you know. So that is the thing with that,
uh,
because we don't know how it works and how it goes in that. That possibility we have to keep in mind in. So basically, with antepartum
yeah
good
that is
surveillance and keeping a good eye on the blood sugar levels, that helps, I think,
exactly.
management in the diabetes during pregnancy.
Yeah, even in second trimester, IUSD is known due to
Yes,
undetected.
yes, sir.
Yes,
There was one patient with
yes,
me,
yeah.
and this patient, everything it was going, and we lost the baby
Uh,
at 32 weeks. And I have one patient which was she was having all BOH cases in that, and this time we used to give around 32 units of the insulin, and I kept for 8 months admitted and control the blood
mm-hmm.
sugar, and we did a section on her and we gave a live baby, which was everybody was saying it was so difficult. So it depends most of the things with the patient and the individualized approach, how we do with the patients. But we have to explain
Yes, yes.
everything for her, because for this patient she was 8 months with me, but so many times we have explained her, and so many times we have taken consent for the all these things with the complications and all.
Because patient है बार-बार क्यों हम लोग का blood sugar आप तपास कर रहे हैं? They say like that, but then we have
नहीं
to
नहीं नहीं, but
explain
we
them.
have to explain. And
डॉक्टर
now
Okay.
there
संदीप
is a
आपका आवाज क्लियर नहीं आ रहा है ना?
and there is a, I can hear him a little bit, but
हाँ,
Okay.
nowadays patient, these people, they are aware of that, because many people they are coming with the preconceptional counseling in a diabetes. A
हाँ
diabetic
हाँ ये
diabetic couple, they are coming for the preconceptional counseling. Then we always say
हम्म,
that ki it should be at least minimum 3 months of the euglycemia, and then you can plan for the
yeah.
conception. That is
Yes,
the ideal
exactly.
thing where you can go for the management role
Yeah.
of the preconceptional. And Ritu, I would like to say one thing is that whenever these patients they are coming with us, don't start on the OHA and all. Give a chance of, if suppose you know, a chance of medical nutrition. Diet is very
yes,
important in this.
yes, I'm coming to that only. Yes, yes, yes.
So diet is very important, because diabetes is controlled, but not only by the insulin or the OHA, but it is being controlled with the proper diet and the physical activity. So this is very important. What do you understand by the diet is that you should have in one thali, half of that it should be with the vegetables and all the seasonal vegetables. She can have a fruits where the less sugar is in that. Then one fourth will be of the proteins, you know, because they will require more than 23 gram of the per day of the proteins in that. And how the patient is, you have to calculate the calories, whether she is sedentary, then go for 2300 calorie, for example. If suppose there is a moderate activity, 3200, if it 2500, if it is a exertional activities, then she can go for a 3200 to 3500 in that. And the fat will be around 10% of that. If you are giving the sugars, then you should go give the sugars, carbohydrates in the form of a complex. You should not give like, you know, jawari hai, bajra hai, gehu hai. These are the things which, because this complex will degrade and it will release the sugar slowly in the gut. But if you eat of the maidas, pastas and all these, this will be directly releasing sugars into the body, and they will have a spikes of that. So this is about the carbohydrate, protein and all these things. But try to tell them to take 3 meals properly, you know, breakfast, then lunch and these things. But in between they should have a snacks and also frequent 2 to 3 hours, small amount of the meals in a pregnancy is to be important to give that. And she should not restrict the activity also, you know, just lying down and all. She can do some yogas, pranayams, light walking and all. So these are the adjustments they should do in that. So we have
Yeah.
spoken about this. Now we will speak about the insulin. So insulin
Uh,
is the one part where you
One
can
minute, 1 minute, Dr. Rajeshri. Here, I want to add, yes, as you have very correctly pointed out regarding this medical nutrition therapy.
गलती
Yes,
से मिल गया गलती से
huh?
क्या हो गया
नहीं नहीं,
medical yes
someone as a speaker as
okay
huh? So regarding the medical nutrition therapy, as you very correct, because we always have to explain our patient that pregnancy is not a disease. उसमें हमेशा सोए नहीं रहना है. Most of the
yes
girls think these days, yes, they are having additional diabetes, so that is a, and plus pregnancy, they are thinking that something कुछ बहुत major हो गया है जिसको वो cope up नहीं कर पा रहे. So we have to explain the patient properly. As Dr. Rajeshri told correctly regarding this pasta, Maggie, sorry, not to take the Maggie, pasta, noodles, huh? And different kind of junk food, especially what the population I am treating, I am getting, they all are very much into this junk food. So I have to explain them. They तो कुछ लोग तो मुझे आकर ऐसा बोलते कि नहीं मैम, पास्ता के बिना तो हमारा दिन ही शुरू होता.
yeah
So
postpone
if you are so they have to do some modification in the diet. Of course, as Dr. Rajeshi told, the complex carbs are good. Yes, if they are very fond of this pasta and all that, I tell them, yes, in the you take a pasta very little, in that you added a loaded of the vegetables. You
yes
add lot and lot of vegetables. So that will at least not that
dal
much of
also
harm. Other thing is the momos. These days, everybody's crazy after momos. Huh? Patients are coming to me, yes ma'am, मेरा PCOS ठीक नहीं हो रहा है, मेरा शुगर लेवल हाई पर है, आप क्या खाते हो? Whenever we are hungry, we are eating the momos. Huh? So momos is again the outer filling is maida, means in the outer coating is maida. In maida they are steamed the things. So there also the some little modification they can take. Instead of maida, some other flour can be used, and we can explain them the inside the filling. They can add some more vegetables. Rest
even
as
dal
Dr.
pulses they can add
Yes.
actually that is the
Yeah, yeah,
important thing.
yeah.
Cow milk
Very
they
true,
can add
very true. Yeah,
so
yeah. Over to insulin. Yeah, yeah. Dr. Rajeshri, you want to share
So
something now about?
insulin is the nowadays we are looking for metformin and all, but as we know, we were students that time. There was only one thing that was the insulin in that. So basically, insulin now it is. I mean, so much of revolutionized it. You know, we are having a rapid acting insulin, then intermediate and long acting. So basically 70/30, you know, so that is the 30/70 is the combination of that. And rapid I feel that ki suppose they are not getting controlled, but to avoid the hyperglycemic incidences, so they can start with the even the rapid acting insulins, because they start in around 20 to 30 minutes of the time. Peak will be around 1 or 2 hours, and then these to avoid the carbohydrate loads you can use for this. And the second intermediate is the what we are using is the isophane or the that is the one there. It is easily maintained, you know, it will start with the 2 hours of the time. Peak will be around 4 hours in that, and it will remain in the body around 10 to 12 hours. So that will give rise to. But there is one condition where there is a brittle diabetes, you know, unstable diabetes. That is the one cause where we are more worried as the obstetrician, because these brittle diabetes, they will be very difficult to get control. There will be more fluctuation. This time it will be around 120, but next time it will be around 180. In that cases, you will have the insulin pumps. They are very good in that, you know, when there is unstable diabetes is there, and according to that they can you can adjust the drugs and you can give it in that, but still in a period of organogenesis. But one important thing is that whenever they are using with the insulin, better see she should not develop the hypoglycemia. That is, so you have to train the patient that what are the signs symptoms of the, you know, hypoglycemia. Like suppose she has a headache, nausea, vomiting, twitching, palpitations, sweating is there, irritability is there, stupor is there. I mean, in that, whenever it drops down in a 70 below 70 sugar, then it will be very risky. That's why they says that during pregnancy it is always the sugars it should be slight at the hyperglycemic side than the hypoglycemic side, because we don't want to give the hypoglycemia to the neonate, the fetus, sorry.
Correct, correct. So thank you so much, Dr. Rajeshri, for covering this very important point. So friends, if there are any questions, Dr. Rajeshri is here, so we can discuss that questions also. So meanwhile, I am receiving the questions. The another session is on this week only, on 12th July, Friday at 9 p.m. I invited one dietitian. So we are going to discuss about the PCOS and diet from confusion to clarity. And on 24th, I am having Professor Abu Bakr Ilnashar all the way from Kerio with me. He is going to discuss regarding the use of the tranexamic acid in OBS and gynec. So all of you are welcome for these sessions. I will post the flyers. And once again, I will thank my dear friend Rajeshri for clarifying lot of confusion. Dr. Rajeshri, I want that we should do one more session on the complications of LSCS, huh? And how to avoid the complications at the time of, because when I posted this flyer ना पता नहीं कितने लोगों का मेरे पास मैसेज आया है इनबॉक्स में कि मैम LSCS के कॉम्प्लिकेशंस के ऊपर एक
No,
करें तो भी
Ritu, we now that wisdom series they are doing on a cesarean section. So they called me on the this thing on the panel on cesarean section. But we will do on the complications of cesarean section also. That will be the best thing.
so you tell me, Miss, accordingly we will, because lot of doctors are having some queries at the time that what to do at the time of the LSCS and what are the problems are coming. So we will take like the
Yes, good idea.
yeah. So we will take on that for the LSCS. Huh?
Yes,
So
done.
we will discuss and finalize one date and we will
Yes.
do with that with you.
Yes.
So Saiti, will you please show the certificate of appreciation?
Madam Rajeshri, do you have any pamphlet
Yes, ma'am.
about diet in pregnancy and X-ray? Just sir, I have written a book just now.
Sorry, I missed
Just
that
sir,
program.
just sir, आपका वीडियो ऑन कीजिए.
हाँ, एक मिनट.
नहीं, I mean, वो book में I wrote very good chapters on the nutrition and all those things. So
This is a token of appreciation to you, dear Rajeshri.
thank
A
you.
certificate of appreciation to Dr. Rajeshri Katke,
Yes.
Professor and Head of the Unit of Grand Government Medical College, for contributing as a distinguished speaker. So thank you once again for sharing your knowledge with us.
Thank you. Thank you. And
So
thank
Dr.
you so much.
Rajeshri has published one book for that is also in the local language in the Marathi, which is very popular these days, because I am also recommending that to my patients also, and all are very happy to read this. So I request you, Dr. Rajeshri, if you can send me that link now, I will post in this. Huh?
Yes, yes, yes.
Huh? Yeah.
Yes.
और डॉक्टर राजश्री इज ऑल्सो वेरी एक्टिव इन ऑल द सोशल मीडिया. यू कैन गो थ्रू दैट. अभी लास्ट ही कुछ दिनों में उन्होंने काफी सारे फंक्शंस किए हैं इसके बुक इनॉग्रेशन के. सो वंस अगेन कॉन्ग्रेचुलेशंस टू यू फॉर दैट ऑल्सो.
Thank you.
So with this we will wind up, friend, today. Already we exceed 15 minutes. So thank you Sahiti, thank you Sheel Pharma for providing the platform. And thank you once again, dear Rajeshri, for clarifying all the doubts. And thank you all dear participants who have joined all across the geography. I am able to see some friends have joined from KRU. Yes.
Thank you, Ritu. Ritu is a wonderful. It is always a pleasure and a great happiness to be on your platform. God bless you, dear. Thank you,
Thank you.
Saiti. Thank you, Shield, and all the participants. God bless you all.
Bye. Bye. Good